A very good day to doctors and all my friends. Today, we would like to present a case study on the disease named Pulmonary Tuberculosis. Without further ado, let us get started with the information that has been given in this slide. Our patient, JKM, has experience with a mild pleuritic chest pain and a protective cough. Chest radiography has revealed the presence of bilateral interstitial infiltrates. Besides, sputum samples have been taken for the AFP smear and culture. He has also done for the PTB skin test. The result of his AFP smear is found to be positive, and the duration of the PTB skin test is 12 millimeters. Therefore, he is diagnosed with the disease named pulmonary tuberculosis. Back to question 1. Discuss my recommendation on the therapy for JKM's condition. By referring to this slide, generally, the causative agent for pulmonary tuberculosis is known as Mycobacterium tuberculosis. Mycobacterium tuberculosis is a small rod-shaped bacilli, and it is a pathogenic bacteria that could infect kidney, brain, spine, but more commonly in lungs. These bacteria are found to be highly contagious because they are capable to transmit from one person to the another through air droplets that is released in the air when the infected person is sneezing or coughing. In this case, a standard anti-tuberculosis treatment is initiated as JKM is just diagnosed from pulmonary tuberculosis. According to World Health Organization, in short WHO, the drugs that are considered as first-line anti-tuberculosis agent are isoniazid, rifampicin, pyrazinamide, and ethambutol. A newly diagnosed patient with pulmonary tuberculosis should be treated for at least 6 months to achieve the desired therapeutic outcome. For instance, 2 months of isoniazid, rifampicin, pyrazinamide, and ethambutol is the preferred 4-drug regimen to be administered for the empirical treatment of pulmonary tuberculosis during the intensive phase, followed by another 4 months of isoniazid and rifampicin during the maintenance phase. The rationale of choosing the 4-drug regimen instead of a single drug is because single drug is more likely to induce drug resistance upon administration. That's all from my part. Next, I would like to invite my next member of Group 10, Yingji, to continue the further explanation on the rationale of drug chosen. Thank you.
Thank you, Yiying. Now, I would like to present about the rationale of choosing each drug for the therapy of our patient, JKM. In this case, each of the drugs in the combinations are significant in treating tuberculosis. For example, isoniazid provides a better cure rate of tuberculosis by killing the dividing causative agent Mycobacterium tuberculosis, while rifampicin is the most active anti-tuberculosis drug, aids in the sterilization throughout the whole treatment. Also, pyrazinamide has a potent sterilizing activity during the first 2 months of the therapy, while ethambutol is used to prevent the emergence of isoniazid resistance. In addition, ethambutol also consists of bacteriostatic effects. Besides, rifampicin should be included in the regimen for a minimum of 6 months. This is because regimens with shorter durations of rifampicin may be associated with higher risk of treatment failure, such as conditions of acquired drug resistance and relapse after completion of therapy. On the other hand, ethambutol may establish toxic effect, which is ethambutol-induced optic neuropathy. Therefore, ethambutol should be substituted with streptomycin if there is optic problem arises in patients. During the intensive phase of treatment, the 4 drugs combination is given as daily regimen. However, the 2 drugs combination in maintenance phase of pulmonary tuberculosis treatment can be either given as daily or intermittent regimen. Intermittent drug regimen will only provided for JKM if he is treated under directly observed therapy, which is also called DOT in short. DOT is a patient-centered therapy which increases the patient compliance towards the tuberculosis management. If intermittent regimen is not administered under DOT, the possible risk of treatment failure, relapse, and drug resistance may arise. Well, that's all from me. Now, I would like to invite my group member, Hui Ying, to explain about the mechanism of actions of drug. Thank you.
Thank you to my groupmate Inji. Now, I would like to present question number 2. Describe the mechanism of the action of the chosen drug, which is isoniazid, rifampicin, pyrazinamide, and ethambutol. So now let's start with the mechanism of the action of the isoniazid. Isoniazid is a product which inhibits the synthesis of mycolic acid. Mycolic acid is significant in the formation of the mycobacterial cell wall to provide the permeability barrier to the hydrophilic solutes. Isoniazid is activated by KG, which exhibits the catalase peroxidase activity. It will convert the isoniazid to the reactive intermediate, which is isonicotinol radical. The reactive intermediates will accelerate the cofactor NADH to form isoniazid NAD-ADA, which leads to the reduction of the fatty acids is unable to catalyze. As a result, elongation of the fatty acid is blocked and the biosynthesis of the mycolic acid is inhibited. Next, I would like to explain about the mechanism of the action of rifampicin. Rifampicin inhibits RNA synthesis by inhibit the bacteria DNA-dependent RNA polymerase. If you look at the diagram B in the slides, the rifampicin binds to the pocket of the beta subunit of the bacteria DNA-dependent RNA polymerase, resulting in the initiation of the chain formation in the RNA synthesis is blocked. Due to the sterically block, the synthesis of the second and the third phosphodiester bond between the nucleotides in the RNA backbones is blocked, which leads to the elongation of the RNA in the 5' is inhibited. As a result, the synthesis of the RNA and the bacteria protein is inhibited. Okay, that's all from me. Now I would like to invite my partner Eunice to explain about the mechanism of the action of the pyrazinamide and the ethambutol. Thank you.
Hi, so here we have pyrazinamide. Pyrazinamide is a bioisosteate of nicotinamide. Actually, pyrazinamide is a prodrug. Once pyrazinamide enters the cell through diffusion, it will be activated into pyrazinoic acid with the help of pyrazinamidase, which encoded by the PNCA gene in the cell. Actually, the exact mechanism on how pyrazinamide acts towards the cell is not entirely known yet. So, I'm going to share 3 proposed mechanisms on how the activated form of pyrazinamide acts towards the mycobacterial cell. The first proposed mechanism suggested that pyrazinoic acid inhibits the aspartate decarboxylase PANDI of the bacterial cell. So, this inhibition will inhibit the synthesis of metabolic cofactors, which are pantotenate and coenzyme A. When these two is inhibited, it will disrupt the fatty acid synthesis in the cell and also the energy metabolism in the cell. So, secondly, it is suggested that pyrazinoic acid increases the acidity inside the cell via a proton shuttling mechanism. So, this increase in acidity will therefore lead to the disruption of membrane energy and function. Okay. The third proposed mechanism suggested that pyrazinoic acid bind to the C-terminus of the ribosomal protein S1, or known as RPSA. This binding will inhibit the translation process in the mycobacterial cell. This inhibition is important to prevent the mycobacterial from being persistent. Okay, for the drug ethambutol, if you look into the structure, ethambutol consists of 2 hydroxyl groups which allow it to mimic the arabinon and therefore inhibits the enzyme arabinosyl transferase. So this will lead to the buildup of arabinon precursor, which is the beta-D-arabinofuranosyl 1 monophosphoryl decaprenol. So this inhibition of arabinon precursor binding will block the synthesis of arabinogalactan AG, and also the synthesis of lipoarabinomannan, LAM. AG and LAM are the important component of mycobacterial cell wall. So the interference of these two, the synthesis of these two, will weaken the cell wall of mycobacterial. Okay, for the next presentation, I'm going to pass to Shazana.
Thank you, Eunice. Now, I will proceed with question 3, where my teammate and I will explain the main side effects of each drug, and we are going to explain the metabolism of reaction of all these drugs. As you can see from the slide, the main side effects of the drugs are hepatotoxicity and visual impairment, where hepatotoxicity is mainly caused by isoniazid, and it also can cause by rifampicin and pyrazidamide, because all of these three drugs are metabolized in the liver, while in visual impairment is usually caused by ethambutol. For the first drug, I will explain about the metabolism of isoniazid. As you can see from this slide, isoniazid will majorly acetylate to form N-acetyl isoniazid. This N-acetyl isoniazid will hydrolyze into acetylhydrazine. Acetylhydrazine will then form D-acetylhydrazine, a non-toxic metabolite, by N82, and this non-toxic metabolite will be excreted from our body. Well, acetylhydrazine will also oxidize into acetyl radicals with the help of CYP450. These acetyl radicals is toxic to our liver, because it will covalently bind to the liver protein and cause hepatic necrosis. And when isoniazid is be taken together with rifampicin, rifampicin can actually induce the second metabolic pathway of isoniazid, where isoniazid will be hydrolyzed into hydrazine. This hydrazine can be acetylated to form acetylhydrazine, and this acetylhydrazine, well, it can oxidize into acetyl radicals, just like the first pathway. Then, in the recent studies, hydrazine can actually cause hepatotoxicity, where it will covalently bind to the liver protein and cause hepatic necrosis too. For your information, rifampicin actually has less hepatotoxicity effect compared to isoniazid and pyrazidamide, because it has non-toxic metabolites. Well, the structure of rifampicin actually induced the CYP450 family and increased the hepatotoxic effect of other hepatotoxic-induced drugs such as warfarin, glucocorticoid, narcotic analgesics, and oral anti-diabetic drugs. When the degradation increase, the toxic metabolite of this drug will accumulate in the liver. And in this study case, rifampicin will increase the hepatotoxic effect of isoniazid and pyrazidamide. Then I will finish my part here, and for the other drugs, we'll be continue with my teammate, Anis. Thank you.
Hello and greetings everyone. Let's move on to the third drug that can cause hepatotoxicity, which is pyrazinamide. Pyrazinamide is a dose-dependent hepatotoxicity. By mean, low dose of pyrazinamide should be given to the patient in order to reduce the drug hepatotoxicity. There are three metabolites of pyrazinamide, which are pyrazinoic acid, 5-hydroxy pyrazinoic acid, and 5-hydroxy pyrazinamide. All these three metabolites are toxic because they can induce cytochrome P450 in the liver that can cause hepatitis. Now let's take a look at how these metabolites are being formed. The major metabolism pathway of pyrazinamide is the formation of pyrazinoic acid that been induced by the enzyme mercosamine deamidase. Later, this metabolite will be oxidized by the enzyme xanthine oxidase, form 5-hydroxy pyrazinoic acid, which is the second metabolite. On the other hand, pyrazinamide also can be directly oxidized by the enzyme xanthine oxidase, forming 5-hydroxy pyrazinamide, the third metabolite. Then, this metabolite can be converted into 5-hydroxy pyrazinoic acid by the enzyme mercosamine deamidase. Therefore, the metabolism of pyrazinamide leads to the formation of these toxic metabolites. The second main side effects of tuberculosis medication is visual impairment. This impairment is caused by ethambutol. Ethambutol usually exists in the isomer configuration. However, the L isomer configuration is the one that possesses the highest optic toxicity that can cause blindness. However, this blindness is uncommon. because the L configuration of ethambutol is less likely to be formed. In the reaction above, the enzyme alcohol dehydrogenase will require zinc ion in its reaction. Therefore, the amount of zinc ion in the eye will be decreased. This can cause visual impairment because zinc is an important cofactor to maintain the normal ocular function. Therefore, if the patient have complaint with visual impairment, the ethambutol medication have to be discontinued. This side effect usually occur to the patient with existing liver dysfunction and eye disease. However, in our case study, since JKM has not been mentioned with any of these conditions, therefore the ethambutol medication is safely to be used.
Next is question 4, asking about drug-drug interactions. So first of all, since in this case study, we propose a combination therapy of 4 drugs, the first interaction that we could list is synergistic interaction between these 4 drugs. Therefore, it will maximize the effectiveness of the treatment. Second interaction is between isoniazid and other drugs. Generally, isoniazid is a potent cytochrome P450 inhibitor where it will inhibit the metabolism of drugs like phenytoin, carbamazepine, and diazepam. Therefore, it will raise the plasma concentration of these drugs, which leads to toxicity. The next interaction is between rifampicin and antiretroviral drugs that are used in HIV-infected patients. On the other hand, rifampicin is a cytochrome P450 inducer where it will induce the metabolism of antiretroviral drugs such as efavirenz. Hence, it will decrease the efficacy of these drugs. The administration of pyrazinamide with probenecid, isoniazid, rifampicin, and ethionamide will increase the toxicity levels of pyrazinamide. Other than that, pyrazinamide will antagonize the effects of probenecid, which means it will increase the uric acid concentration. Therefore, it is very harmful for gout patients. Last for drug-drug interaction is ethambutol with ethionamide. Ethionamide is a second-line anti-TB drugs where it will potentiate the toxicity effect of ethambutol. Isoniazid and rifampicin both have interaction with food and antacids, where food will delay their absorption, therefore will lower the plasma concentration of these drugs. On the other hand, antacid will increase the gastric pH that will reduce the absorption of these drugs as well. In addition, isoniazid also interact with theramine histamine containing food like cheese, red wine, where it will cause side effects like headache, tachycardia, diarrhea, flushing of the face, and hypotension. Meanwhile, pyrazinamide has no interaction with food and antacids, therefore its absorption will not be affected. Last but not least, interaction of ethambutol with food as well as with antacid, where ethambutol interact with food but has minimal effect only, so absorption of ethambutol is not affected much by food. But on the other hand, antacid will decrease the absorption of ethambutol, therefore they both should be administered apart. That's all from me. Thank you very much.
After the treatment of the tuberculosis has been decided, we need to conduct a monitoring plan to monitor the efficacy, safety, and drug interactions of all the drugs.
Plan to monitor efficacy. The first parameter is mild pleuritic chest pain. We need to interview the patient after 7 and 14 days of the treatment. And the goal to achieve is the productive cough should be disappear after 40 days. And the second parameter is weight. We need to monitor the patient's weight monthly during the treatment, and the patient's weight should be increased gradually. The third parameter is white blood cell count. The blood test should be rechecked after 24 to 48 hours of the treatment, and the white blood cell count should be reduced. The fourth parameter is interstitial infiltrate. Chest radiograph should be carried out at the end of the treatment and also for every 6 months. The chest radiograph should show slight improvement. And the last parameter is sputum sample. AFP smear and culture should be repeated during the last dose of the intensive phase treatment. And the goal to achieve is the AFP smear should show negative result. However, if the sputum sample shows positive result at the end of the month 2, we need to carry out sputum sample microscopy at the end of the month 3. And if the sputum sample is still positive after the end of the month 3, we need to perform drug susceptibility testing and also sputum culture because it might be due to the multi-drug resistant tuberculosis. Next, we will see the plan to monitor the safety of the anti-tuberculosis drugs.
Next, we move to plan to monitor the safety of isoniazid. The common side effect of isoniazid is peripheral neuropathy. If the patient complains on muscle weakness, numbness, or pain, we should monitor them by performing nerve function tests and interview the patient after 24 hours. If there are no more numbness or pain, it means this drug is safe to be used to the patient. Next one is rifampicin, which can cause hepatotoxicity. To ensure this drug is safe to the patient, blood tests should be performed to ensure the liver enzyme level is in a normal level, as this indicates that this drug is safe. Hyperuricemia is a common side effect of pyrazinamide. Patients should undergo blood and urine tests to ensure that their creatinine level is in a normal level after consuming this drug. The last one is ethambutol that can cause optic neuritis to the patient. To indicate that this drug is safe to be used to the patient, eye tests should be performed after 1 week of drug initiation. If there is no development of optic neuritis, it means this drug is safe to be used. The last one is to monitor the possible drug interactions. If the patient consuming isoniazid with food that contains histamine or tyramine, it will increase the risk of histamine and tyramine allergies. However, we can monitor by carrying out quick tests for histamine allergies. If it shows negative results, the patient can continue the medications. Besides, we also can carry out an elimination diet for 14 to 30 days. Patient need to stop eating histamine-rich food for 21 days and reintroduce the food every week and observe the results. If no reaction is observed, the patient is not allergic to histamine. The other possible drug interaction is with alcohol, as it can cause hepatotoxicity. We should monitor patient's liver enzyme level to ensure that there is no elevation in liver enzyme.
Next, continuation of the case study statement. Number 1, in addition to the therapy, physician prescribed pyridoxine for JKM and was started with intensive phase therapy. Number 2, after a week of the therapy, during the follow-up, JKM liver enzyme, both AST and ALT were elevated 5-fold from the baseline value. Number 3, he also complained that his urine now is dark orange in color. Now for question 6, we will cover on the chemistry perspective for elevation of chosen drug on why the liver enzyme were elevated and the urine of the patient is dark orange in color. For the first part of question 6, which is regarding the elevation of the liver enzyme, isoniazid is a hydrazide that is readily oxidized. Oxidation of isoniazid will produce 3 metabolites. The 3 metabolites from isoniazid are suspected to be responsible for the isoniazid-induced liver injury, which are acetylhydrazine, hydrazine, and a most recent metabolite resulting from the bioactivation of isoniazid itself. A reactive metabolite resulting from the bioactivation of isoniazid will form covalent bond that will bind to the liver macromolecule. It shows that the reactive metabolite of isoniazid can react with several lysine residue on the hepatic proteins. Covalent binding of the drug to the hepatocyte shown to be a very important factor of the hepatic toxicity. Glutathione is transferase responsible in the phase 2 conjugation and excretion of the drug intermediates. With slow acetylator, the half-life is between 2 to 5 hours, but with fast acetylator, the half-life is reduced to 1 to 2 hours, leading to a build-up of acetylhydrazine and the toxic intermediates. These hepatotoxins are able to bind covalently to the macromolecule and the liver protein, causing necrosis of cell, forming free radical. Free radicals are a common source for oxidative stress and act like domino effect, leading to the liver damage, causing elevation of liver enzyme. I will pass the explanation regarding of the coloration of the urine to the next presenter.
Thank you, Salam, for the wonderful explanation. Now I shall continue on the explanation to why the color of the urine is dark orange. Rifampicin is a polyketide that belongs to a group of antimicrobial agents known as ansamycin. As you can see in this diagram, rifampicin has a basket-like structure containing an allophatic chain that connects two ends of a naptoquinone core. This naptoquinone core is what gives rifampicin its red-orange crystalline color. Alright, we get it, rifampicin has a red-orange crystalline color, but how does the urine turn orange? Well, firstly, it takes 6 hours for rifampicin to be completely deacylated from the system. 6 hours is quite a long time. It is also easily absorbed in the GI tract. The ester functional group is hydrolyzed by the bile, and it is catalyzed by high pH and substrate-specific esters. Because of this easy absorption, it leads to a high distribution of drugs in the body organs, body fluid, and even the cerebrospinal fluid. So it is not uncommon for the color of the urine to be dark orange. It is also possible for the saliva, tears, and even feces to be orange color.
Hello and greeting everyone. Finally, I will discuss about the last question, which is question 7. This question is asking about the best management for JKM at this stage and the rationale of giving pyridoxine for him. Based on the statement, JKM's liver enzyme AST and ALT level were elevated 5-fold from baseline value without symptoms such as nausea, vomiting, diarrhea, and gastrointestinal disturbance, indicating tuberculosis drug-induced hepatitis. How can we know that this hepatitis is due to drug or not? The first condition is when the liver enzyme AST and ALT level is increased more than 3 times upper limits of normal range in the presence of symptoms, or the patient comes with the AST and ALT level increasing up to more than 5 times upper limits of normal range without symptoms. TB drug-induced hepatitis usually occurs in 20% of patients on these 4 drugs. So, the best management for JKM is to continue his drug therapy but may increase the frequency of monitoring. Since JKM is newly diagnosed with pulmonary tuberculosis, the physician will monitor the liver function test for every 2 weeks to see any progress of hepatitis and to ensure either the treatment is well tolerated or not. Next, I will explain the rationale of giving pyridoxine to JKM. We know that one of the drugs that JKM take is isoniazid, and the most important side effect of isoniazid is peripheral neuropathy. Vitamin B6 or pyridoxine supplementation during isoniazid therapy is necessary in some patients to prevent the development of peripheral neuropathy. The activity of pyridoxine in this metabolic function is competitively inhibited by isoniazid. Isoniazid inhibits pyridoxine phosphokinase, which is required to convert pyridoxine to pyridoxal 5-phosphate, the cofactor in many pyridoxine-dependent reactions. Therefore, pyridoxine medication is rational to be continued for JKM. A 10 mg dose of pyridoxine for each 100 mg of isoniazid appears sufficient to prevent pyridoxine deficiency. Furthermore, the administration of pyridoxine does not interfere with isoniazid's anti-tuberculous action. That is all from me. I will pass the slide to Tahsi.
Thank you everybody for your wonderful explanations. So, in summary, Mr. JKM was diagnosed with pulmonary tuberculosis, causative organism of which is Microbacterium tuberculosis. He was started off with a 6-month standard treatment plan where he was given 4 anti-TB agents: isoniazid, rifampicin, pyrazinamide, and ethambutol. He was also put on a monitoring plan where he was monitored for his efficacy, safety of the anti-TB drugs, and possible drug-drug interactions. Side effects of the therapy may include hepatotoxicity from different drugs at different levels. Later on, additional therapy was introduced to Mr. JKM where he was prescribed pyridoxine, and he also mentioned having a dark orange color in his urine, which was due to the consumption of rifampicin. Therefore, at this stage, Mr. JKM should continue his therapy just with increased frequency of monitoring. And with that, we have come to the end of our presentation. We hope everything was clear, easy to understand, and up to the standards. Thank you so much for viewing our presentation and listening. We hope you liked it. Goodbye, stay safe, and stay home.